Hello, good morning to everybody. I am Dr. Chaudhary Mahesh. I'm a consultant neurosurgeon working in L Raheja Hospital, a Fortis associate at Mahim. I passed my neurosurgery way back in 1983 from Bombay University and have been in this field over the last 40 years now. I have been a professor and a teacher in Maharashtra Health University where we take candidates for MCS neurosurgery as selected on the all India basis. Now, today I have come to meet you and talk with you regarding certain aspects of neurosurgery. That's what you call as newer advances which have taken place over the time. Since the time we started neurosurgery has grown in leaps and bounds. So many new things have come up. Essentially, we consider that into multiple headings. Now, what has happened is the technological advances have taken place, which are in the field of diagnostic. Then there are technological advances which have taken place in the field of treatment, in the form that there are many things which help us in whilst we operate. The things that change a lot in pathological aspect, and then subsequent treatment which is followed. We cannot completely cover all the topics in such a short period. However, the certain things I like you to know about it. Now, initially we had only CT scan. Later on, the MRI scan came into picture for diagnostic purposes. Now, CT scan has advanced with the facility to have higher pixels, so the clarity of the scans is much better. Simultaneously, in MRI, there are so many other things which have come up. We can have MRI spectroscopy, you can have MRI diffusion scans, we can have functional MRI scans, so on and so forth. Now, all these things add up to our management of brain tumors. In fact, nowadays, whenever we refer a patient for diagnostic purposes, seen by a neurosurgeon, we refer the patient to the MRI scan department with a note, kindly follow a protocol. So, protocol MRI is done. In a sense, it will tell us added things which are required in brain tumor surgery. Now, it is much easier to judge whether patient is having a malignant tumor or a benign tumor. Plus, if it's a case of a malignant tumor, it will tell us something more about the more benign and more malignant part of it. So, corresponding to that, we can select biopsy areas or the excision part of it. As you are aware that some parts of the brain are called as vital areas, like speech cortex, like sensory motor cortex, wherein if you try to do something, the damage is more likely to occur. Some areas like brainstem, midbrain, pons, and medulla are very vital. A time was there when we could not operate these areas so confidently. However, over the time, because of these advances, it has become possible for us to find out whether a tumor is compressing or it is destroying that particular area. Now, all these functions of brain, as you are aware, so there is a cellular structure, there is a tract structure. Now, if you do a tractography on MRI scan, you will see the various tracts which are required for, like, say, speech cortex, like you say, the motor functions, they are delineated. And you can demonstrate them on the MRI scan, because of which you can easily find out well in advance, pre-operatively, whether the tract has got a possibility of survival after operation. In fact, many times we select the surgical aspect from that angle and then we take care of it. So this has made a lot of advances. This has also made an advances in cases of surgery for the Parkinson's disease, where we can be much more accurate now. Now, regarding the vasculature also, earlier DSA was the gold standard, which is still remains the gold standard. However, better techniques of CT angiography and MR angiography have helped us now for a non-invasive aspects of the neurosurgery. We need not do any invasive procedure and still we can know much more about the tumor part of it. We can have a 3D reconstruction of the same. Now, this 3D reconstruction of the face and the skull has also helped us in many ways in different aspects, like not only the brain tumor, but also suppose you want to do some reconstructive procedures. There are certain conditions wherein you can find that the facial and the skull have got a congenital defect. So these patients need to be operated because you want to expand the skull, you want to expand the orbit, so that patient's vision is not at stake. So if you do the 3D reconstruction studies, you can exactly determine the extent of the surgery, which is many times done along with the plastic surgeons. Many times we can remove, or we feel that a patient has met a head injury and then he has got a bony loss because of the direct injury, direct destruction of the bone. In such cases, we have nowadays 3D reconstruction studies, and then corresponding to that, we can do a reconstruction during surgery. We can have earlier different things were available. Now there are inert materials which are available, and in fact, they provide us 3D models well in advance. So with that helps us in getting the exact cosmetic picture as we want. Now, these recent advances, as I have been telling you, have led us to many things. Like what we have been talking all these years nowadays is minimal access surgery. Now, minimal access has become a D word in the fields of various branches of the surgery. Neurosurgery is no exception. It can be used in an area where it is easily accessible. Commonly, the supraorbital approach, which can be used for what we call the front area of the brain and the basal area of the brain, where orbital tumors can be tackled, where meningiomas, like the tumors arising from the dural folds. So various meningiomas like olfactory groove meningioma, planum spinatal meningiomas, or skull base, other meningiomas which lying in the anterior skull base territory can be tackled if they are in reasonable shape through a small supraorbital area. Sometimes we can tackle certain aneurysms, which are like a middle cerebral artery aneurysms or anterior communicating artery aneurysms. These can be tackled through the small incisions. Now you are aware, or you must have been hearing a lot, like recently endoscopy has come into the picture. It's not so recent, in fact, it's been there for a long time. But neurosurgical endoscopy has advanced its wings quite a lot. Now we go transnasal, transspinatal, which earlier days we had to do essentially the transcranial approaches. Like we had to take a big incision over the skull and then open the flap and go with the base of the skull, base of the brain, and then reach a tumor which is lying in the sella turcica and the superior part of that, what we call as supracellular part of it. Now we can approach the same lesion from down, like transnasal or transspinatal area. So pituitary tumors, craniopharyngiomas occasionally, then the meningiomas originating in the midline essentially, not with so much of a lateral extension, can be tackled safely through that area. Another tumor which can be done through the transspinatal nowadays is chordomas. These are the tumors which are from the notochordal tissues at the skull base. Now these are very invasive tumors. But many of these tumors, which are not going too much laterally, can be tackled safely by the endoscopic route. Now, endoscopy has also advanced in quite significantly with better endoscopes available, pediatric endoscopes available, various angle connections available, and the illumination along with the vision is far superior. So practically in some of these cases, we can send the patients home within next 2 to 3 days as well. Endoscopy has also extended to the spine. So now we can do endoscopic spinal surgery for disc, prolapse intervertebral disc. We can do it for lumbar canal stenosis. We can do the decompression of the lumbar spine, and in some cases it can be done very well, of course, with adequate training in spinal cord tumors as well. There is a steep learning curve for all these procedures, so naturally the experience matters. Though the procedure can be done, it's not necessary that it can be done by just in just the beginning. You need to be trained properly for the same. Now, if we see, we have been operating these brain tumors for a long length of time. Now, what are the things which have changed in the surgical aspect? The most important thing, we are more accurate. Now, how have we achieved that accuracy? यहाँ एक नेविगेशन का प्रोसीजर किया जाता है, what we call navigation protocol MRI or navigation protocol CT scan, wherein the data is obtained while the patient is investigated and the data is transferred before operation, after anesthesia, on the patient through the computer, and that computerized data tells us exactly on the patient's head which is the ideal area and what is the extent of the area what we want whilst we operate. So the surgical exposure is only in a concerned area. Exposures have become smaller and more accuracy is there. Now this is very helpful for one more reason, is what we call it biopsies. Earlier days we used to do biopsy, what we call a stereotactic biopsy with frames. Patient was fitted on a frame and then the scans were done according to that, and then after getting back from the scan center we used to perform the role according to the need and then we used to do the biopsy. However, now the need of frame is not there. What we call it frameless biopsy can be done, navigation guided biopsy can be done, and which is done very safely and much faster also. If it is necessary, sometimes this the navigation can be used to do a very small craniotomy, which again fits into our minimal invasion, and then that can give us the total excision or the biopsy depending upon what is the need of the situation. So that has helped us a lot. Now, once we have done a proper framing, proper navigation, and we have marked the flap, there are many things which have helped us inside whilst doing the surgery. Most the best being the microscope. We have much better microscope with much better illumination, much better magnification as well. Now there are occasionally we need retractors. Now those retractors are far better now. So once we reach the tumor, how will we identify the tumor? If it is a benign tumor, well, it's not so difficult. It is different from the surrounding tissues, so we can identify it much easier. But if the tumor is malignant, then we have got various dyes which we can inject to the patient and that's get illuminated under the microscope. So we can continue to remove the tumor until we feel that now no more illumination is available and we have practically excised almost completely the tumor. So thereby it gives us more complete excision of the tumor. Of course, as I have been talking to you, there is something called as the intraoperative MRI. Now, intraoperative MRI will add up to the accuracy further. It will tell us exactly whether we have removed the tumor completely Now, this is all the more important because some areas are such that we cannot enter very aggressively. So we have to think in advance whether removal of this tumor in this particular part is going to be safe or not. So we have to be very accurate. Simultaneously, we also want to remove the tumor completely. So it heals. It helps in this intraoperative analysis. At the end of it, we know now we are satisfied that the tumor excision is complete. So these things have added a lot to the surgical field. We have what you call as Cavitron ultrasonic surgical aspirator, Cavitron, CUSA, what we call it. Now, this CUSA breaks the tumor tissue into multiple small fragments. So, what happens is you require less amount of pulling and pushing of the tumor. So, naturally, less destruction of the surrounding tissue. So, since there is a less trauma to the surrounding tissue, post-operatively, patient gives a better clinical picture with no neurological deficit if we have selected the areas properly. Plus, it adds up to the speed of the tumor removal. The lesser amount of time for the tumor removal, naturally, the lesser complications of the anesthesia and subsequently the handling of the brain is less amount of time. So everything has added up to the things. Another thing which is advanced nowadays is the agents which we use for stopping the bleeding during surgery. Earlier days we used to have only gel form. Now we have got better Surgicel, Hemlock is there. Now there are some names like Flossil, now which helps us in stopping the venous blood much more efficiently, much more quickly without really bothering about it. Of course, the sad part is that these all these things I have added up to the cost of the procedures. One has to bear with it because if you want to have a better results, everything matters. Now, earlier days, whenever we used to finish surgery, we used to complete the dural closure with conventional things. Now we have got much better material which is easily acceptable to the body. So we can close the dura much better. Sometimes if there is a dural closure is extremely difficult, we have got dural substitutes which are available, dura foam, new dura, and that helps us in closure of the procedure much better. Bone fixation has improved. Formerly, we had to fix up the bone using only the sutures. Now we can do it much better by using the mini plates and screws. So patient has got better cosmetic appearance as well post-operatively. Antibiotics, as you are rightly aware of it, that they are better, medicines are better. So naturally, this recovery of the patient is far superior now. In fact, many of these cases now, we are able to send patients home within next 3 to 4 days. If you use the absorbable sutures, then 2 3 days is more than enough. In spine cases, occasionally we send the patients in a day. If we see, just the way neurosurgery has advanced, recent advances have helped us in getting better utilization of the various advances and the results improving. Post-operative ICU care has improved a lot. Now we have got better monitors and of course the better trained people as well. So the patient's complications are picked up much early. Around the clock facilities are available. Once the pathology is sent, we get the reports pretty quickly. Sometimes in the frozen section facilities are necessary. But histopathology, suppose it comes as a malignancy. What to do next? If you find that nowadays there are various tumor markers are done, so these help for us in better judgment of the future of the patient. If patient requires a radiation therapy, definitely radiation has changed a lot. Earlier cobalt was there, it has changed to LINAC, it has changed to gamma nap. Gamma nap has come to picture. Then proton beam has come into picture now. Now gamma knife is something which can be used very safely when the tumors are less than 3 centimeters in size. In areas where they are relatively inaccessible, or when you try to remove, it's likely to cause more damage. So in such cases, gamma knife makes a wonders. Cost is a factor, but definitely it causes less of damage to the surrounding tissue. It remains more stress, more localized to the tumor part of it. So overall, we feel that all these technological advances have added up to the patient's brain tumor care much better. I have been interested more in all the types of tumors. However, microsurgery has evolved so much that these uh, these tools have been helping us quite a lot. Now I am able to operate the patient while patient is awake as well, what we call awake craniotomies. In certain areas, like suppose there are motor speech area, then we want to check whether we are causing any damage during the surgery. So what we do is we do the patient's operations when the patients are awake. Naturally, this special type of anesthesia is required and a special type of training is required for them. So during the surgery, we keep on checking whether the patient is able to speak, whether the patient is able to move the corresponding area of the body. And as soon as we find that there is a problem, we naturally stop for a while and find out whether that is returning back. Simultaneously, there is something called as neuro monitoring now. These are the various gadgets which are added to, like what we call motor evok potentials, somatosensory evok potentials, the cranial nerve control, like a fifth nerve cranial nerve, facial nerve control, lower cranial nerve like 9, 10th, 11, what we call. Now these nerves preservation is extremely important so that patient, once this is operated, is not only the patient should be freed of the tumor, but also patient's originality should return back. A lot matters in facial nerve surgery, acoustic neuroma surgery. Now these are the tumors which originated in the CP angle area. They originate essentially from the vestibular nerve. So these patients come to us with hearing deficits, or if the tumor is big, then we have some facial nerve problem. We can have a taste affected. We can have the some other low cranial nerves affected, or if it is bigger than that, it causes compression in the brain, causing the hydrocephalus part of it. Now we take care of all these things. So we, because of the microsurgery, because of this monitoring, we are able to preserve the facial as well. We sometimes we are able to preserve the patient's hearing as well. That has been my priority all these years. Of course, there's a thinking nowadays that sometimes once the tumor is very small and it's safe to remove it, you can remove it. But if it's little unsafe, if it's little more adherent, then you can leave it for the gamma knife as well, or just watch for the growth of the tumor. So everything has added up to the improvement in neurosurgery. I hope these technical words have not caused any undue stress to people, and it has helped you people quite a lot in understanding the advances in neurosurgery over the last 15, 20 years. And India has been able to keep pace with all foreign countries as well. So one doesn't have to worry too much about it. I think most of the facilities are available here, and tumor surgery can be done safely. So if you are unfortunate to get these problems, don't get scared. Please try to go to a correct institute and take a benefit out of it. Thank you very much.